Good morning. I'm Haritha Tatavarthi, and today I'll be presenting the case of Richard Taylor, who is a 56-year-old male seen today at the Central Clinic with persistent depressive symptoms, including loss of interest, fatigue, guilt, and difficulty concentrating. Symptoms have worsened over the past 6 months. Social history: he's an IT specialist, married for 24 years, wife passed away last year, currently living alone. He's a current smoker and he smokes one pack per day. Alcohol use is occasional and has increased recently due to the holiday season. Exercise, none. Illicit drug use, none. Diet, increased caloric intake in the last 3 months, and he has gained 15 pounds in the past 6 months. Family history: father deceased at 62 from cardiovascular disease. Siblings, no significant medical history. Family history of depression is present. He is allergic to adhesives. Current medications include metoprolol succinate, 50 milligrams, PO daily, fluticasone, 100 microgram inhalation twice a day, albuterol, 2 puffs every 4 hours as needed for shortness of breath. Atorvastatin 80 milligrams daily, aspirin 325 milligrams PO daily. High priority problems include depression and COPD. Low priority problems include myocardial infarction, obesity, hypertension, and hyperlipidemia. Assessment of his disease of depression: he has severe depression with no suicidal ideation, manic episodes, or anxiety. It has worsened with grief and holidays. Symptoms meet the criteria for major depressive disorder. Assessment of current therapy: his depression was initially treated with citalopram 3 years ago, which helped with symptoms but caused erectile dysfunction and diarrhea, leading him to discontinue the medication. So, therapeutic plan would be to start him on bupropion SR 150 milligrams every morning. So even though the 2023 APA guidelines for major depressive disorder suggest that SSRIs and SNRIs are the first-line therapy, based on his history of citalopram-induced erectile dysfunction and diarrhea, I would start with the bupropion SR. And this may also aid in smoking cessation. Non-drug therapy would include cognitive behavioral therapy and lifestyle interventions, including structured daily routines, social engagement, peer groups, grief counseling, and then gradual physical activity. Monitor for side effects of bupropion, such as insomnia, dry mouth, headaches, nausea, and dizziness. Assessment of his COPD: he has dyspnea on exertion, no frequent exacerbations, and low eosinophilic count. So this would likely put him in the gold B category. Assessment of current therapy: his low eosinophilic count suggests that RT's COPD may not be driven by eosinophilic inflammation. This means that he's less likely to benefit from inhaled corticosteroid therapy, and therefore fluticasone can be discontinued. Therapeutic plan: per GOLD guidelines, switching RT to a LAMA a combination therapy such as Trelegy, Ellipta, 1 puff daily would probably work better for his symptom control. Continue albuterol 2 puffs every 4 hours as needed for shortness of breath. Non-drug therapy would be to refer RT to pulmonary rehab to improve his exercise tolerance and to encourage gradual reduction and cessation of smoking. Follow-up: schedule RT for a follow-up appointment in 1 to 2 weeks to assess his initial response to bupropion and ensure that he's tolerating the medication well. If everything is stable, subsequent follow-ups would be in 4 to 6 weeks for both his depression and COPD management. Thank you.